Dear colleagues, let me first thank the scientific committee and, of course, AstraZeneca for the kind invitation to talk about an everlasting question whether we can reduce the mortality of our patients in CKD population based on the data that we currently have from new agents. These are my disclosures. And I will start with previous old studies that were saying, and we know that our patients die, and they die far more commonly and more frequently than they end up on dialysis due to comorbidities that frequently coexist with these patients: heart failure, coronary artery disease, diabetes, anemia. Indeed, mortality burden has been rising since 1990, and it has been rising both in the diabetic and the non-diabetic population. As we know from the general population, 1 in 10 do have CKD, and this number of CKD patients increases rapidly, and they do die far more frequently. And it has been estimated that it will be the 5th cause of death by the year 2040. This, of course, will be a huge burden both for the health of our patients and the economies in the health field. This data should prompt, of course, major efforts to develop preventive and therapeutic measurements in order to decrease the incidence and to reduce the rate of progression. The rates of RRT, renal replacement therapy, will be rising, and the projected number receiving RRT is estimated to increase to more than 5 million by the year 2030. And together with a surprising increase in death rate by 160% by the year 2040. And as GFR declined, there is an increasing risk for non-atherosclerotic cardiovascular disease, LVH, arrhythmias, and in parallel, there is an increased risk for fatality with a sudden death. And the finding of increased cardiovascular events and mortality is closely associated with a decreasing GFR and the increasing albuminuria, which emphasizes exactly the importance of the cardio-renal interaction in clinical practice, not only the diabetic, but also in the non-diabetic population. And our patients die regardless of the primary cause of their kidney disease, which reflects a common pathway that leads to increased mortality. And as we see here in these 3 cohorts, all patients, regardless of the fact that they were on maximally tolerated RAS inhibition, they did have a very high increased risk for death. So we understand that the risk of cardiovascular disease in CKD is driven by kidney-specific risk factors in conjunction with both traditional, such as hypertension, and non-traditional risk factors, such as inflammation. And the chronic disease progresses and kidney-specific factors do increase and become more prominent, and the risk of cardiovascular disease is then amplified. Indeed, CKD is associated with heart failure, as is seen here, both in the patients with preserved as well as with patients with reduced ejection fraction. And this association is bidirectional, and as heart failure is associated with the risk of kidney function decline. Up until recently, there was an unmet need in the therapeutic field and an effective treatment for CKD to prevent development and progression of CKD disease and to prolong survival. In the last couple of decades, the only agents that we had and proven to decrease the progression was the RAS inhibition. But here we see that even on RAS, maximally tolerated RAS inhibition, patients with CKD and a GFR less than 60 and an albuminuria greater than 30 did have a difference in the survival, even by minus 20 years, depending on the age group that we are looking at. So this unmet need and this therapeutic gap are coming SGLT2 inhibitors to fill this gap. To fill the therapeutic gap with this novel anti-diabetic, at least initially only anti-diabetic drugs, initially used only for diabetic patients, by blocking the reabsorption of glucose and sodium in the proximal nephron, and therefore enhance the glycosuria natriuresis, which in turn causes the increased osmotic diuresis due to the feedback. But these agents initially, sorry, how do I go back? Yep. So these agents initially, and these are the three main and initial clinical trials, the CANVAS, the EMPA-REG, and the DECLARE-TIMI. They were used in diabetic patients with only minimal decrease of their renal function and minimal, if any, albuminuria. The three major initial trials, the EMPA-REG for empagliflozin, CANVAS for canagliflozin, and DECLARE for dapagliflozin, were evaluated, and they showed significant results in the three-point MACE for cardiovascular death, myocardial infarction, or stroke, in combination with a combined endpoint of heart failure hospitalization or cardiovascular death. But at the same time, there were coming experimental models that started to use SGLT2, and here is the experimental model of unilateral nephrectomy, a CKD model, that showed that dapagliflozin was able to reduce the proteinuria and to reduce the loss of the podocytes. And therefore, based on various experimental models, the clinical trials continued to try these agents in three trials, and one of them is DAPA-CKD. And DAPA-CKD did randomize 4,300 patients. One-third of the patients were non-diabetic, the two-thirds were diabetic, and the eGFR range was between 25 to 75, with a range of UCR of between 200 and 5,000 milligrams per gram. The majority were on stable dose of RAS inhibition, and then they were randomized one-to-one in dapagliflozin 10 milligrams versus placebo. And the results were significant. And the primary endpoint, which was the substantial decrease of greater than 50% of eGFR, end-stage kidney disease, or renal or cardiovascular death, showed a 39% risk reduction when compared to the two arms of the study in the 2.4 years of the follow-up. The effect of dapagliflozin was significant, and it was irrelevant from the stage of the kidney disease. So it was across all subgroups significant, both in the diabetic and the non-diabetic patients with UACR less or greater than 1,000, and with an eGFR less or greater than 45. The significance was observed in all three groups, whereas for the secondary outcome, for the all-cause mortality, and this is the first study that we have this signal about all-cause mortality, the decrease in the dapagliflozin group was tremendous, 31%, the risk reduction of the death in these patients, and therefore the study was prematurely terminated due to this overwhelming benefit of the drug. According to this, we have the different causes of death, and what was observed in the 5.7 participants that died in the follow-up period, the 36% had a cardiovascular death, whereas 41% had non-cardiovascular causes, and 22% was non-determined. From the non-cardiovascular death, both infections and the malignancies were the primary causes of the non-cardiovascular death, both in the diabetics and in the non-diabetics. During the follow-up, dialysis was initiated in 167 patients, and 37 participants died in this group, compared to 12% in the dapagliflozin group. And deaths were recorded in 210 in the group that did not reach dialysis. 89 died in the dapagliflozin group versus 121 in the placebo group. So there is a significant difference in the number of deaths, and dapagliflozin prolonged significantly survival in patients with CKD, with or without type 2 diabetes. And survival benefit was consistent across a range of patients subgroups and was mainly driven by reduction in the non-cardiovascular causes, such as malignancies and infections. These accounted for total 41% in non-cardiovascular death reduction. And the effect of dapagliflozin on mortality was consistent across pre-specified subgroups and did not vary among subgroups for any primary cause of kidney disease. Additionally, the beneficial effect of mortality of dapagliflozin was not affected by the stage of CKD or by the presence or absence of pre-existing cardiovascular disease. So we see that both in the primary and in the secondary outcomes in the DAPA-CKD trial, all the endpoints, both primary and 3 secondary causes, outcomes, were all significantly reduced with very high percentages. In the death, 31% risk reduction, and I repeat that this signal has not been seen previously in other trials. And the benefit with dapagliflozin is clearly independent, according to this analysis, from the levels of the glycemic control, so it's irrelevant. Sorry. So it's irrelevant from the levels of the HbA1c. And we see that the point estimate for the hazard ratio is below the line of unity across a wide range of levels of HbA1c. According to a trial that had for patients with both reduced and with preserved ejection fraction, dapagliflozin showed also benefit, significant benefit. Here we see 26% of reduction risk and 18% of reduction risk in the primary endpoint of cardiovascular death. Whereas in the DELIVER study, where there were randomized patients with preserved or minimally reduced ejection fraction, 23% showed a risk reduction in the cardiovascular deaths and worsening of heart failure. So how can we say that SGLT2 inhibitors preserve kidney function in patients with kidney disease due to causes other than diabetes mellitus? And how do we explain the benefit in heart failure seen in non-diabetic patients as well? In this case, there is no tubuloglomerular feedback. The tubuloglomerular feedback could explain the first question and could answer this. However, in the heart failure, there is no tubuloglomerular feedback involved in the Frank-Starling curve. The third question is it merely due to natriuretic effect at play, and why don't we see those kind of benefits with other natriuretics? The answer comes with experiments that have shown that dapagliflozin, in this case, has reduced intravascular volume when compared relatively to the interstitial volume, less than the traditional diuretics. So we can see that intravascularly, the diuretics contract the volume, the intravascular volume, whereas the SGLT2, and specifically in this study, it was dapagliflozin. It reduced less the intravascular volume, and mainly it affected the interstitial volume that we see during cardiovascular disease and heart failure. And therefore, this may limit the reflex of neurohumoral stimulation, and that occurs in response to intravascular volume contraction with traditional diuretics. And therefore, we can say that it reduces, compared to traditional diuretics, the stimulation of the sympathetic system. There are other novel mechanisms of cardioprotective benefit of SGLT2 inhibition. And we see here that it can improve the metabolism in the myocardiocytes by increasing the ketone bodies. First of all, by increasing ketone bodies, the cardiomyocytes can use them as a better fuel energy sources. And therefore, we can conclude from various mechanisms that SGLT2 inhibitors can improve cardiovascular outcomes. Mechanisms of action of SGLT2 inhibition, apart from the cardiovascular action, has been seen not only due to the reduction of the intravascular volume, but also due to reduction of the body weight, reduction of the adipose tissue, and increase of the hematocrit due to improvement of erythropoiesis. Indeed, the erythropoietic mechanism is improved with SGLT2 inhibitors because it reduces the reabsorption of glucose in the proximal nephron, and therefore it reduces the production of AGEs, where the production of erythropoietin is taking place, and therefore it improves the release of erythropoietin and increases the hematocrit. Indeed, as it has been seen by analysis from the cohort in the DAPA-CKD, placebo had 29% anemia in the placebo group, whereas in the dapagliflozin, the 53% of anemia was corrected when the 10 milligrams daily dapagliflozin was used. Among other mechanisms, of course, they lead to reduction of other important parameters such as HbA1c, systolic blood pressure, body weight, and mean urinary ACR when compared to placebo, which has, of course, in total effect on survival, and therefore we can explain the findings from the DAPA-CKD for total survival. In addition to the decrease to the total body weight, it is not only due to the diuretic, natriuretic effect, but also, as has been seen here with the use of DEXA scan, it decreases the adipose tissue. One of the cases, it can decrease also the cardiac adipose around the heart muscle, and therefore it can improve the contractility. So we can see that there are various mechanisms that lead both to the renoprotection, and here comes the tubuloglomerular feedback, of course, but also the cardioprotection, which is induced by various mechanisms, as I mentioned, increase in erythropoietin, improvement of the contractility of the cardiomyocytes due to the increase of the ketone bodies that can be used as a source for energy of the cardiomyocytes, and total positive inotrope action. Something is happening here. According to the 2023 KDIGO preview that was shown in the ERA-DTA in Congress this year in summer, the recommendations are that basically, they are recommended treating patients with type 2 diabetes and an eGFR of greater than 20 ml per minute with SGLT2. And the second recommendation is treating adults with CKD and heart failure or an eGFR greater than 20 ml per minute with urine albumin to creatinine ratio, ACR greater than 200. But the unmet need from the trials, they haven't been yet tested or evaluated in patients that we looking after, such as dialysis patients, transplant patients, or patients with EGFRs just before dialysis, which are with an EGFR less than 20. And therefore, this trial has been designed, and it's estimated that it will be completed in 4 years, the renal lifestyle trial. You see here the total design. It's a randomized double-blind study, an umbrella trial. The primary and the composite outcome will be all-cause mortality and hospitalizations for heart failure. And the secondary outcomes will be incidence, each component of the composite outcome, incidence composite in each of the 3 patients group, and safety, of course, and tolerability, whether SGLT2 inhibitors is safe to be used in these patients. These are the 3 groups, people living with advanced CKD on dialysis or transplant patients. So we saw that DAPA-CKD from the DAPA-CKD using dapagliflozin reduction in all-cause mortality in CKD was noted, something that it has not been seen in other trials, and improvement in kidney disease outcomes being equally effective, of course, in non-diabetic and diabetic patients. And I will close with a quote for Sir William Osler, who said that the young physician starts life with 20 drugs for each disease, whereas the old physician ends life with 1 drug for 20 diseases. Thank you.